He is senior resident in radiation oncology in Max Hospital, Paparganj. And the panelists are Dr. Akansha Grover. She is senior resident in radiation oncology at Max Vaishali. Dr. Ravinder Kaur. She is senior resident at MAMC. Dr. Tanshi Daljit. She is senior resident at MAMC. And Dr. Anshu Mangala. She is a surgical oncologist and head and neck fellow at Rajiv Gandhi. Dr. Disha Tiwari. She is medical oncologist. And Dr. Devesh, he is also doing DNB medical oncology in Apollo. Both are in Apollo. And Dr. Swati Nair. Dr. Swati Nair is surgical oncologist and head and neck fellow at Medanta. So we have full of our surgical oncologist, medical oncologist, and radiation oncologist. All are here. Dr. Akshay Kashyap, you have to moderate the session. And this session will be supervised by Dr. Manoj Tayal. He is Director Radiation Oncology at Max Hospital, Paparganj. Dr. Kanuj Malik, he is surgical oncologist, senior surgical oncologist at Yatharth Hospital, Noida. And Dr. R.K. Chaudhary, he is senior medical oncologist and director at Metro Hospital, Noida. So over to you, Dr. Akshay Kashyap.
Thank you, ma'am. Good evening, everyone. Am I audible?
Yeah, you are audible. Please share your PPT.
Yes, audible, yeah.
So, good evening, everyone. I'm going to discuss a case about oropharyngeal cancer, which we treated in the recent past. It's a case of a 69-year-old male who did not have any comorbidities such as diabetes, hypertension, or complaints of change in voice and sensation of lump in throat with mild dysphagia. In personal history, he was a smoker, did not use alcohol, or did not have a family history of carcinoma. He was examined, and clinically, on physical examination, clinically there were palpable left level 2 nodes present of size 2.2 by 1 centimeter of size. He was further evaluated with flexible laryngoscopy, biopsy, and FDG PET. So I would request our panelists to Dr. Akanksha to suggest if we needed to do something more. Hello?
Hello?
Yes.
Am I audible?
Yeah, Dr. Akanksha, please.
Yes, sir. So we have taken the history and physical examination and done the flexible laryngoscopy and biopsy. So if we are going for FDG PET, then that will suffice because it will take care of the primary nodal disease as well as the distant mets in this case. So I think the investigations being done are sufficient for the patient.
I would request our other panelists to comment on was there any need for MRI in this case? Dr. Kaur, Dr. Ravinder Kaur, can you comment, please?
Sir, MRI, good evening, everyone. MRI, sir, as such, MRI is to be done if we have to look for if there is any perineural invasion, or other than that, sir, in this, sir, CECT of like head and neck will otherwise suffice for looking the extent of the tumor, including the involvement of neck nodes.
I think we can also go for the thyroid function test because eventually we need to radiate the patient, and we'll also be needing an HPV also. P16 would do, or HPV DNA.
Yes, that is all correct. I would also like to comment on Dr. Ravinder's remark that CECT would definitely shed light on nodal status or bony erosion, but the soft tissue delineation, the extent, the submucosal extent to be particular, is more clearly defined by MRI. So MRI
Okay.
definitely has an important role here. So I'll move on.
Dr. Akshay, I have one question from you. Is PET-CT must for doing myelostate investigation in all the like is just so what is the basic minimum staging investigation we should ask for? Because PET-CT may not at all the places all the time. So what is the basic staging workup imaging you will ask for? So a patient with the oropharyngeal cancer.
Absolutely, sir. The very basic staging workup starts with the proper history and the physical examination, followed by laryngoscopy, which can be done on OP basis, or if it is a difficult one, then we can do an evaluation under anesthesia, which will also facilitate taking adequate biopsy sample for a definitive diagnosis of carcinoma. On the aspect of imaging, the very basic minimum requirement would be a CECT, which is, yes, definitely informative, but for soft tissue delineation, contrast enhanced MRI can also be advised to the patient. For as far as PET-CT goes, PET-CT is actually complementary, which is more preferred in the patients who have locally advanced disease, might have a risk of metastatic disease. So essentially to rule out metastatic status of the system as a part of systemic work of PET. But patients or CMRI or contrast enhanced MRI.
मेरे को ऐसे टाइम मिलता है जब मैं फ्री होती हूँ आपको खेलना होता है मैं ये बात आपको हमेशा से ही आप अपने शेड्यूल
Yes, sir. If if the patient has some constraints or there's lack of resources in which PET-CT cannot be done, then yes, definitely we can go ahead and get the least we can do is such as X-ray and abdominal ultrasound. So we evaluated the patient with a flexible laryngoscopy, and we found that there was a growth in the right ventricle crossing the midline, reaching up to the base of the tongue and involving the lingual surface of the epiglottis. The false vocal cord and other relevant structures were normal, and the vocal cord was also normal and mobile. Biopsy revealed that it was a moderately differentiated squamous cell carcinoma.
So my question from Dr. Anshu is, if this lesion was not so obvious and doing biopsy or doing FNAC, what will you prefer? FNAC of the lymph node or biopsy from the primary site? Dr. Anshu.
Good evening, all the senior mentors, my fellow colleagues. Sir, we have already done the DL scopy, so we will take the biopsy of the lesion.
Okay. So you will not prefer to do a FNAC, you will prefer to do a biopsy.
Sir, FNAC from the node can be done, but if the lesion is evident on DL scopy, we will definitely take the biopsy of the primary lesion and get the P16 IHC, P16 done.
Okay, so biopsy is always preferable as compared to FNAC. So FNAC we should consider only when we are not sure about getting enough tissue for diagnosis. So in that case, you can consider FNAC, but yes, biopsy is always preferred. Yeah. So go ahead, Akshay. Yeah.
I have a question, sir, if I may.
Can you identify yourself first?
Yeah, I'm Dr. Kanuj. I'm Dr. Kanuj, surgical oncologist, sir.
Yeah.
I mean, we are adamant on doing P16 ISC. I want to know from any of the panelists, how would P16 ISC affect your treatment management in this patient?
Yeah, question is on the panelist.
Good evening, sir. Sir, actually, till now, from the value of like IHC of the P16, there has been no difference in the treatment for HPV positive or HPV negative tumor. But as it has been discussed earlier also in the slides, that for HPV positive tumor, as they have good prognosis, for low risk HPV tumor, it can be considered for intensification of the treatment for those patients. But as per now, there is no difference in treatment between HPV positive and HPV negative. However, it is a prognostic marker.
Now, if a
till
patient
now.
has come to you with a clinically palpable node of 2 centimeters, I think that was the size, do you still feel the
sir.
need of doing a P16 ISC?
So sometimes the patient presents with a large nodal mass without we knowing the primary. So in those cases, if we know that it is P16 positive, we can come to a diagnosis that it is a oropharynx cancer, and we can treat it according to the management of carcinoma oropharynx. Other than that, sir, for as of now, there is no difference in treatment for HPV positive versus HPV negative tumors.
So for carcinoma of unknown primary, yes, has significance,
Yes, sir.
but otherwise it is mostly of prognostic value.
Yes, sir.
Please, Dr. Akshay, please go ahead.
Yeah, Dr. Kanuj, you are right. Actually, in previous first lecture, it has been discussed. According to NCCN, carcinoma oropharynx actually has been divided in staging also for P16 on the basis of P16. So that's why we should try to do P16, but we should not be
Absolutely,
adamant in
ma'am.
our conditions. Yeah, in our conditions, if the patient cannot afford and not interested, so
That is
in
what
exam
I
you should
mean.
say. Yeah, in exam you should say, but in practice, if situations are not favorable, you can avoid. And so I request our students to please open your video, okay, so that you can know each other, and when you know each other, maybe these mentors, maybe your examiner, and can guide you better at that time also. Okay, it will be beneficial for you if you don't mind. Over to you, Dr. Akshay. Thank you so much.
So next, we did the body PET CT, which showed us that there was a heterogeneously enhancing soft tissue lesion of 3.5 by 2.5 centimeters. It was in relation to the epiglottis involving the base, crossing either side of the, it was extending either side of the midline, and was extending into the pre-epiglottic space without abutting the hyoid bone, without having a cortical erosion, and was also extending along the paraglottic space, more on the left side, with bilateral level 2 cervical lymph nodes, largest on the left side of 1.5 by 1 centimeter in size, and SUV uptake of 3.8. So these are the two representative images of the PET CTs. So I would request any one of the panelists to suggest about the staging. Dr. Swati, can you stage the patient now? I'll go back to the clinical findings here.
It would be a stage 4 disease, considering there's involvement of the epiglottic space and the larynx. It would be a stage 4 disease.
Can you specify actually if what is the TNM stage?
So it would be a T4A N2C disease. M0.
So I'll just share the T staging with you. Now, can you stage it again?
It is T3 disease as the lesion is extending to the lingual surface of the epiglottis.
Yes, absolutely. It's a T3 N2C disease with disease extending on the lingual surface of the epiglottis.
But you also mentioned that the disease is extending into the pre-epiglottic space with involvement of the
Since there is involvement of pre and paraglottic space, I don't think it will be T3, it must be T4.
Exactly.
Yes, for the latest CNM staging for the P16 negative patients, the T4 is defined as T4A or T4B, in which moderately differentiated locally advanced lesions invading the larynx, extension muscles of the tongue, major pterygoid, hard palate, or the mandible qualify as T4A. And a tumor invading the lateral pterygoid plates, or lateral nasopharynx or skull base, or encasing the carotid artery is defined as T4B.
So whether it is the size of tumor larger than 4 centimeter but not involving any of these structures is categorized as T3. So this tumor is not going into the extrinsic muscles of the tongue, and the pterygoids are free. The palate obviously is free, and the mandible is also free in this patient.
But the pre-epiglottic space is involved, so that should be considered as a part of the.
This is just a space; it's not a structure. So the
So actually, pre and paraepiglottic, they are just spaces. They are not involving the entire larynx. So we'll consider it as T3 N2C disease. This is Dr.
Yeah.
Tanshi from Molana.
Sir, I have one query, sir. So the epiglottis is a fenestrated structure and it is in direct contact with the pre-epiglottic space. So if pre-epiglottic space is involved, then there are high chances that epiglottis must be involved.
No, okay. So if the epiglottis is involved in a case of oropharyngeal carcinoma when the lesion is in the vallecula, so a tumor larger than 4 centimeter in greatest dimension or extension to the lingual surface of epiglottis is T3. And but if it is going into into the laryngeal surface of the epiglottis, then it is T4. So there is a difference here that we have to understand.
Okay.
Okay. So since we are in agreement that the stage TNM staging for the patient was T3 N2C M0. Now my question would be to our
now Dr. Akshay is going to ask a question from Dr. Swati only because she is a surgeon. Yeah.
So Dr. Swati, how would you further advise the patient?
If we can, I think for this particular patient, considering the extent of disease, and I think the treatment would be to go for a CTRT upfront.
Okay. So the surgeon has given opinion that now this patient should be taken up for radical CTRT. So, Dr. Ravinder Kaur, what is your opinion?
Yes,
How about your opinion? Will you consider giving this patient radical chemoradiation, or you have some other plans in your mind?
Sir, actually, sir, can you please show me the previous slide? I just skipped where is the primary. I just know it is oropharynx. Soft tissue mass lesion in relation to epiglottis involving base of tongue. Okay, sir, it is a base of tongue lesion. I will also prefer going for, sir, CTRT, definitive CTRT for this patient, sir.
So basically the size of the lesion, it is large and it is involving the base of tongue. So basically whatever surgery we'll have, it will be a very morbid surgery. So the better option for this, since it is a locally advanced disease, is to go for a concurrent chemoradiotherapy.
Next question to Dr. Tanshi Darjeet.
So I've just answered this.
Okay.
No, sir, sorry. I was talking about.
So, Dr. Tanshi Darjeet, could you tell me what volumes would you plan for?
Volumes.
So basically, sir, over here we would be taking the GTV, the CTV, and the PTV over here. So the GTV will include the gross disease which is present and the enlarged node which is present. And for the CTV, we'll take the GTV, and we'll be including the margin since it is an N2 disease. So we'll be including 1B, 2 to 5 lymph node, and the retroperitoneal nodes. And for the gross disease, we'll give a margin of.
Retroperitoneal, you mean to say?
Yes, sir, retroperitoneal nodes.
Okay.
So for the CTV one, we'll include the GTV, and the margin will be given as 0.5 to 1 centimeter around the primary, and 0.3 to 0.5 centimeters around the lymph node. And we can also take in the high risk areas over here. That will be CTV2, and the PTV will be given as CTV plus 3 to 5 millimeter margins.
Okay, so
So the 70 grain 35 fraction.
yes. So if we need to refine your target volumes, do you put any definition to your targets, the intermediate risk, the low risk, the high risk? So can you refine your target? So which all group of lymph nodes or the primary primary clinical target volume you will consider as the high risk or intermediate risk, and what all the group of lymph nodes will consider as low risk. So can you refine a bit so that you can give a better prescription to your targets?
Sir, in CTV, high risk lymph nodes, as level 2 is already involved. So, sir, CTV in lymph node level 2 will be a high risk lymph node. And sir, other than that, sir, level 4, these will be intermediate risk in case of this patient. And in CTV, nodal involvement, which we have to take bilateral, but high risk will be the involvement, the largest lymph node, which was on. There are bilateral level 2. Both of these bilateral level 2 will be high risk CTV and mein aayenge, sir.
Okay. So, Dr. Akshay, would like to know, in a case of carcinoma oropharynx, what all are the lymph node levels we should always take into our volume? So, can you define those level of lymph nodes?
Yes, sir. Sir, the first equivalent for the oropharynx is level 2. And the most commonly involved lymph node levels are level 2, 3, 4. But if level 2 or level 2 or level 4 is involved, then we'll have to go to level 5. Well, one level up and one level down. So if level 4 is involved, then we'll have to go for level 5 as well. And there are data which suggests that even if when more than one lymph nodes are involved, then we should go for level 5 as well.
Okay, so as per the latest guidelines which are published in 2019, and as per them, for any oropharyngeal cancer, level 2, level 3, level 4, level 5, they should be minimally treated. And based upon the involvement of level of lymph nodes, then you add on to these, whether you want to add retropharyngeal lymph nodes or whether you want to add level 1 lymph nodes, level 1B basically, and level 6 also. So this is how you go about it. Okay. Yeah, Dr. Akshay, you want to go further? And
yes. So since we have already defined the volumes, excuse me. So I would request our radiation oncologist panelists to participate and prescribe the volumes also to the respective risk volumes for, let's say, intermediate risk and high risk volumes. So how much dose would you want to give?
Dr. Ravinder.
Sir, with these, so in high risk, the high risk volumes, we have to go for the GTV and high risk volumes. We have for the GTV we have to go up till 70 gray according to the conventional fractionation, 70 gray in 35 fraction, and for intermediate and low risk, for intermediate risk, we can go till like 54 to 66 gray to those areas. And other than that, sir, if we are using a modality IMRT with SIB, simultaneous integrated boost, and in those cases the gross disease can receive a 2 gray fraction, and other than that, if the disease is having risk of microscopic involvement, high chances of microscopic involvement, we can give them at a fraction of 1.6 gray per fraction, and other than that, for normals, for the normal structure where it is going, 1 gray per fraction is the dose which is received by those tissues.
So 1 gray per fraction, you need to say should be our dose
So-
constraints.
So for dose constraints, so for example, sir, as the parotid also are coming in the treatment field, so to reduce the dose volume to those to the mean of less than 26 gray, ideally to the mean of less than 26 gray to the parotids.
Okay, so you will prefer to do IMRT, CRT, or PAT. So what is the option
Sir,
we have here? Yeah.
Sir, IMRT is preferred over other techniques. IMRT is preferred over, sir, 3D CRT and conventional 2D technique, as there is reduced dose to the mainly to the parotid and sir, the pharyngeal constrictor muscles to reduce the dysphagia associated symptoms and the xerostomia, which is caused by the dose which is given by the sir 2D and 3D CRT. IMRT is preferred over these techniques.
Okay, so you will do IMRT and plan for 70 gray to the high risk and 60 gray to the intermediate risk volume. That's what you mean to say, right?
Yes, sir.
Want to keep your main doses to the parotid to 26 gray if possible, and
Yes, sir.
those max to the spinal cord not more than 45 gray, right?
Yes, sir.
Yeah. Now, my next question is from our medical oncology colleague. So, Dr. Disha, how about your opinion? We have been talking radiation. How about neoadjuvant chemotherapy for a patient like this?
Good evening, everyone. This is Dr. Disha Tiwari, medical oncology resident from Apollo. So, particularly in this patient, or for that matter, in any patient of locally advanced.
2 घंटे में से मैं आर्यमन से परेशान हूँ. क्या हुआ? बोला तुमने क्यों मीटिंग लेफ्ट किया? मैम मेरे को ऑडियो नहीं आ रहा. हाँ, कुछ मैम ने क्लिक सेंड किया और बोला ज्वाइन करो अभी, और मैंने ज्वाइन किया और मेरे को ऑडियो नहीं आ रहा.
Please mute yourself. Please mute yourself.
Yeah, Dr. Disha.
Dr. Disha, are you there?
Okay, we'll ask this question from Dr. Devesh.
Hello.
So, and then we'll ask comments from Dr. R.V. Chaudhary also. Then you can take the discussion further as well.
So this is Dr. Disha. Am I audible, sir?
Yeah.
So, sir, for good evening, everyone. So, for particularly in this case, I would definitely not like to advise for neoadjuvant chemotherapy, because it is a locally advanced oropharyngeal cancer, and we can very well treat this patient with the chemoradiotherapy. However, we can definitely advise the patient, considering the bulk of the disease, maybe we can advise the patient to add nivolumab, which is a epidermal growth factor inhibitor, EGFR inhibitor, because we have evidence for adding nivolumab, especially in cases of locally advanced head and neck cancers. We have the study from the Tata, which included the patients. The patients were undergoing chemoradiotherapy along with the concurrent chemotherapy of cisplatin, along with the addition of nivolumab 200 mg flat dose. So we are using nivolumab in our center in the head and neck cancer patients with the huge burden of disease.
Okay, so you mean to say that adding nimatuzumab will have additional benefit in addition to.
Sir, as per the study, that the evidence we have from the Tata study, there was a disease-free survival benefit and the PFS benefit. However, there was a limitation of that study because in that study, the dose of concurrent cisplatin was somewhat lower. So that's why that study was criticized. So they used 30 mg per meter square, which we are not giving as a which is not a recommended standard dose. So that is the one scenario. But however, the results were somewhat encouraging. So we are in our center, we are giving for the high burden patients we are adding nimatuzumab.
Okay. Dr. RK, you have, we want your comments also, boss. Dr. RK Chaudhary, are you there? I think Dr. RK is not here. So
Earlier he was there, I don't know.
Akshay. So, Dr.
Yeah, I was mute, I think.
Akshay. Okay, yeah.
Sorry, Dr. Akshay. I was going to. Yeah, please.
So we want your comments also on role of chemotherapy in neoadjuvant setting in oropharyngeal cancer. I'm Dr. Manoj speaking.
Okay. So, who's the medical oncology resident?
Sir, I am
Dr. Disha and Dr. Divish.
Sir, I'm
Yeah, hi, Dr. Disha. So Disha was talking about the neoadjuvant and combining the biologics with the platinum-based, right?
Yes, sir.
So still there is no standard guideline to add these biologics along with the chemotherapy. In practice, people are adding with the I think more better PFS, but this also adds the cost. So when we plan any treatment, then we need to see the financial aspect also. Yes. And regarding induction chemotherapy, I don't think there is any role of induction chemotherapy in this base of the tongue. But coming to since this discussion is is for the resident doctors who are going to be exam going in near future. So I think it should be limited to that only. So I'll comment to the previous discussions where they started with the staging system discussion thing. I think during the exam stage, the discussion goes more towards the clinical examination, investigation, and the staging rather than treatment part. Right, Dr. Akshay?
Yeah. So that's why you are our.
So when you ask some residents
you should be guiding this discussion further. Yes.
Right. So when you ask some residents for the staging, she directly said, "Okay, it is the stage 4." I think the examiner won't like this comment. They won't like this kind of comment. So you need to be very specific about the TNM staging. Then at the end you can uh, uh, comment about the stage as the 1, 2, 3, 4. Right. And specifically in oropharynx, if the P16 has been not done, then if some examiner asks for the staging, you must ask what will be the what is the P16, because the staging system also incorporate the P16 thing. As discussed extensively about the role of P16, whether it is a prognostic or any role in therapy. So as of now, there is no role of P16 in therapies or the except prognostic and the staging thing.
Yes. Yeah. So on that note, I would also request you to shed some light on 3 weekly concurrent chemotherapies versus weekly chemotherapies.
So my comment is,
Yes.
yeah. So I am not using 3 weekly protocol since I have been trained in an institute where we were comfortably given the weekly doses, and both the options are there as per the guidelines. Also in practice, we are now into practicing this weekly regimen for quite long time, and we're finding the equivalent results. This is convenient, more tolerable, and we are able to give the sufficient dose. In 3 weekly, many times people were not able to give the third dose. So I'm pro for the weekly dose, and I'm using weekly dose in my practice.
So would you still consider 3 weekly in any one? Can you give one example in which you consider 3 weekly, although you don't do it?
Your voice is not clear.
So, can you give us one example, sir, in which you would prefer doing 3 weekly chemotherapy versus only the usual weekly chemotherapy?
I'm practically not using at all, so I won't be able to comment about any. I've never used 3 weekly, even during the training time or institutes never used this 3 weekly, and where we are using the cisplatin in youngers and maybe higher doses if patient is young with good BSA and fit without any comorbidity, but not 3 weekly.
Okay. Thank you so much, sir. Dr. Devesh, what other agents can we use as a part of concurrent therapy along with radical radiotherapy?
Sir, I'm Dr. Am I audible?
Yes.
Yeah, thank you, sir. I'm Dr. Devesh from Apollo. Other agents that can be used are definitely if the patient is cisplatin ineligible by any means, like the hearing impairment or kidney function text is deranged, then we can add cetuximab to those patients in accordance to the Bonner trial. And there is a new study from Tata, I guess, where they're using docetaxel weekly. I think around they're using now 20 to 25 milligram per meter square weekly dose, and it had shown a very good results. I'm very sorry, but I don't remember the results currently. But definitely, other agent which Sir and Dr. Disha has said regarding biomap, that is the agent biomap which was added along with cisplatin. There is a Scott N study. There is a Scott N study, I guess, which clearly showed that the overall survival was not significant when we use biomap along with the cost factor. And definitely in younger patients, like from the older trial, 5-FU on cisplatin concurrently have been used along with radiation, which have shown good results. But currently, cisplatin weekly dose is the standard of care. To be very frank, standard of care is 3 weekly 100 milligram per meter square. But in our center and wherever we have seen, everybody is using weekly 40 milligram per meter square. But then I think there is a very good standard trial which is supposed to give the results. I guess there is an NRG trial from National Registry Cancer, where they have enrolled many patients. The phase 2 trial has already undergone. The phase 3 trials, the results are still awaited regarding the 100 milligram per meter square versus 40 milligram per meter square. But the results are still awaited. We are waiting for the results. But I think standard of care will be 40 milligram per meter square cisplatin if the patient is eligible for that particular dose or for that particular chemotherapy.
Thank you so much. We would want to, like we discussed, we planned for.
Akshay, your voice is not clear.
Hello, am I clear now?
Now, yes.
Okay. So we subsequently planned to treat the patient with radical radiotherapy and concurrent chemotherapy. The treatment was done by defining the CTVs as intermediate risk and high risk. The intermediate risk CTV received 60 gray, and the high risk CTV PTV received 70 gray. So these are the representative images for the 60-day dose distribution. And this is the 70-day volume which we treated. So at this point, go back again. At this point, I would need comment from Dr. Akshay about what to expect during the treatment. What side effect profile should we expect?
Okay. So the side effects that I expect in this patient are oral mucositis, xerostomia, dysphagia, dermatitis, weight loss, and since patient is having dysphagia, so NG tube dependence, and the patient is being given chemotherapy along with radiotherapy, so hematological toxicities, And such patients, they usually complain of altered voice during treatment ki awaaz baithi hui hai. These are the common complaints, acute toxicities that we see in these patients.
So what is the role of PEG in the case of severe oropharynx or any other tube?
Sir, if there is significant, hello? Hello, sir, am I audible?
Yes, please go ahead.
Okay, so if there is significant weight loss, like 5% weight loss in last 1 month, or more than 10% in last 6 months, then patient should be given prophylactic PEG tube should be inserted, or NG tube should be inserted.
So how about doing a swallowing assessment for these patients if there is a silent aspiration and further increased risk of aspiration? Then these patients should be considered for tube feeding rather than oral feeding, so that we can prevent aspiration pneumonitis. And those patients who are not able to maintain their nutrition with the oral route. So, and very bulky disease, and the lumen is already compromised. So these are the few cases, we might consider. Otherwise, oral, continuation of oral feeding is always preferred in irradiation of any head and neck cancer, because the rehabilitation becomes a problem in these patients. They become tube dependent and becomes a task to get them off tube feeding. Yeah. So pre-treatment swallowing evaluation is important. Dental evaluation is important. At the same time, the speech therapist also should be involved, and the patient should be advised to continue with their mouth opening exercises also.
So, as we discussed, the patient received 7 doses of weekly chemotherapy. First, his doses was of cisplatin, and the last dose was given of carboplatin because the patient had deranged KFT. The toxicities we observed, one of radiation-related toxicities missing here is what is xerostomia here. Otherwise, he had grade 2 dermatitis towards the end of the treatment. I mean, started with after 3rd week and continued to have grade 2 only. Mucositis was grade 3 week 4 onwards, and dysphagia was grade 2 week 3 onwards. Chemotherapy related, we found that patient was having neutropenia on once or twice, which was managed with neokyne or colony stimulating agents. Next, I would need comments from. Sorry.
So, Dr. Akshay, meanwhile, I will ask Dr. Kanuj, he is surgical oncologist.
Yes,
Dr. Kanuj, any comments from your side regarding radiation side effects? Or do you think anything can be decreased when you if you do surgery?
Ma'am, not really. I mean, these side effects generally tend to wane off over time.
Posterior by facial. Okay,
am I audible, ma'am?
Yeah, you are audible. You are audible.
Okay.
So, actually, I was thinking people are preferring a TORS. People are suggesting TORS in early stages, T1, T2.
Yes,
so
ma'am.
do you think which side effect can be reduced when you are doing surgery?
Ma'am, with surgery, like as in previous discussion, it was mentioned that we have to check for the swallowing, and if the swallowing is perfect, is good, then yes, your side effect of dysphagia even post surgery will be very less. And considering like this patient had a side effect of dysphagia and this mucositis, these all will be significantly reduced with TORS. Although this case is not suitable for TORS, as the stage is T3 into C.
Yeah, Dr. No. Yeah, you are right. But when we are doing TORS, we are already taking patients whose swallowing function is, you are saying, is all right.
Absolutely.
But but when we are doing radiotherapy, we do not consider this. We just do radiotherapy. We do not check. I don't think anybody checks for anybody checks for swelling, and so that's how thing happens. So I think
So the outcomes of
our
TOS, I'll
radiation oncologist
say,
and
are a
surgical
little biased.
oncologist, yeah.
Yeah,
Outcomes
Rashi,
of
you are
TOS are
right.
slightly biased because we choose our patients very carefully.
Yeah, Rashi, you are right that people do not give so much of attention to these things, but they are very important, and they should be given equal importance in the overall, when you consider giving radiation to these patients. So pre-treatment swelling evaluation, pre-treatment dental evaluation, pre-treatment, these patients require a lot of rehabilitation later on. So it's better to start even before you start your treatment. So that's what we should re-emphasize everywhere, that this thing should be given full attention.
Yeah, I think already 9 is there. So one comment is from Dr. Ashok. Dr. Ashok, if you are there, you want to say something regarding your trial, if you want to say something with these guys.
Good evening, ma'am. How are you? The trial
good,
was.
sir. Yeah.
Thank you. Thank you. I was listening very intently with all the comments made by all the residents. So this was a very long, old trial dated in 2009. So we added cisplatin nimotuzumab along with cisplatin. The dose of cisplatin was not reduced. It was at 40 milligram per meter square, and nimotuzumab with the standard dosing. But overall, I did not find much difference between the two groups, which was cisplatin alone and cisplatin with nimotuzumab. The overall survival was not different. There was hardly any difference with the toxicities. Yeah, as far as the adverse events was concerned, they might have been some differences like low magnesium levels and oral mucositis, but not to a very great extent. Overall, I would still suggest that cisplatin, an age-old member of our onco community, should be used rather than adding nimotuzumab. Obviously, Dr. RK had mentioned that it will unnecessarily increase the cost. We yet to receive some more good trials, a long-term outcome of nimotuzumab trial. Then we can incorporate this drug into our daily practice.
So thank you, Dr. Ashok. Thank you so much. So Dr. RK, do you want to comment anything, or you want to say anything?
Dr. RK, are you there?
So
I think Rashi,
I should.
Yeah, we are to the end of our session here, and we are really grateful to our panelists, and I would like to thank Dr. RK Chowdhury and Dr. Anuj Malik, my co-mentors, for Dr. Akshay, Dr. Ravinder, Dr. Tanshi, Dr. Anshu, Dr. Disha, Dr. Devesh, and Dr. Swati, and thank you to Dr. Akshay also. He has prepared the case well. And I hope we can keep on improving upon these exercises further. So over to you, Rashi.
Thank you so much, Dr. Manoj. So this class was for students and by the students. So I think we will keep on improving. And at last, I would like to thank Dr. Mrs. Nidhi Mittal. She has arranged all these things, and Dr. Meeta Goyal and Dr. SVS Dev, Dr. Kanika, and all other members of Oncology Forum who has arranged this meeting. And I would like to thank all participants who have participated and actually listened properly. And I'll request all, please circulate this among your students and please participate so that you can have more it can be more beneficial when you are giving exams. You know, in exams, all these questions will be repeated, as has been asked in this. So thank you so much. So over to Dr. Vinita Mittal, Vinita Goyal. Dr. Vinita, do you want to please announce about next class?
So thank you, Dr. Rashi, and thank you everyone for actively participating. I think it was a very useful session. And the next class, now decided that these classes will be twice every month, and on Monday evening, 7 to 9 p.m. Next class is on 27th February, which is again a Monday. It will be on early breast cancer, only on triple negative breast cancers. If any one of you are interested, in presenting or being the panelist, being the active participant, please drop a message to either me or Dr. Rashi Agrawal, so that we can include you as panelists or presenters. Thank you so much, Dr. Rashi, once again.
Thank you so much, ma'am. Thank you so much. Thank you, everyone.
Thank you, ma'am.